everyone, and welcome to the Surgical Ergonomics podcast, where we will be discussing everything related to surgical and procedural ergonomics, the people, ideas, and technology that will help enhance your physical wellness and career longevity. I am your host, Geeta Lal. I'm an academic endocrine surgeon, speaker, consultant, and surgical ergonomics coach. Having experienced work-related musculoskeletal injury myself, I am committed to increasing awareness of and developing solutions to counteract the impact of poor ergonomics on the professional and personal lives of healthcare workers in procedural areas. Today's episode is sponsored by Q-Optics. Surgeons, your neck shouldn't pay the price for precision. It's time to demand loupes that are built for you. Q-Optics is more than magnification. Custom crafted through the lens loupes engineered and tailored to your unique facial structure and surgical posture. The ultra lightweight titanium build eliminates pressure points, red marks, and the chronic neck and shoulder pain caused by heavy, bulky, outdated optics. With the exclusive TrueFit measurement system, each pair is precisely tailored to your unique facial structure, delivering a customized stress-free fit and all-day comfort. The Ergo Direct Vision loupes with up to 60 degrees of declination keep neck flexion under 15 degrees, or go zero flexion with the Ergo Angle Deflection loupes for a straight-ahead gaze and complete ergonomic relief. And with crisp edge-to-edge clarity within an expansive peripheral view around the telescopes, your field stays wide and unobstructed. Transform your OR experience today with a 45-day trial and exclusive pricing for listeners of this podcast. Visit qoptics.com/Dr. Lal to learn more and schedule your demo with a local representative. And again, don't forget to use the code Dr. Lal to claim your discount. Your work demands precision. Your body deserves relief. Q-Optics, designed for comfort, built for performance. Hello, everyone, and welcome to another episode of the Surgical Ergonomics podcast. Today, I am delighted to have as our guest Dr. Patricia Trbovich. Dr. Trbovich is an associate professor in the Institute of Health Policy, Management, and Evaluation, and cross-appointed at the Institute of Biomedical Engineering at the University of Toronto. She holds the Badeau Family Research Chair in Patient Safety and Quality Improvement at North York General Hospital, in addition to her other appointment at U of T. She is the Research and Scholarship Lead, Center for Quality Improvement and Patient Safety, also called C-QuIPS. Patricia also leads HumanEra, a team dedicated to enhancing healthcare safety and performance through human factors research. With over 15 years of experience, she's implemented health technologies and trained professionals worldwide. Now, she is focused on advancing surgical safety through innovative tools such as the OR Black Box to identify safety threats to provider and patient safety, apply human factors principles to operationalize resilience, and prototype and test human factors informed interventions. Hello, Patricia, and a very warm welcome to our podcast today.
Hi, Geeta. Thanks for having me.
Of course. So, listen to a little bit about your background in the intro. I was wondering if you might be willing to share with our listeners a little bit more about your personal background, including where you grew up, where you trained, and how you arrived at your current role.
Sure. So I grew up in a small town, Elmer, Quebec in Canada, which is just about 30 minutes away from Ottawa, our nation's capital. And that's where I did both my master's and my PhD. So I did my master's degree in cognitive psychology, and that really gave me a solid foundation for understanding how people think, how we process information, how we make decisions under pressure. And then from there, for my PhD, I pursued a field that was new to me at the time, human factors. In fact, it was referred to as human-computer interaction at the time. And I was drawn to it immediately because it really allowed me to apply the psychology background in very practical ways. Human factors is all about understanding how we can position people for success, but not by expecting them to accommodate poorly designed system, rather the other way around. So my cognitive psychology background was really helpful in that. And then during my PhD, I worked at Transport Canada in their ergonomics
Wow.
and crash avoidance division. Yeah, it was really interesting. And at the time, there was a ban on handheld cell phones while driving.
Ah.
And so the research was really focused on understanding, is it really the physical holding of the phone that's causing the distraction versus, the just the fact that you're carrying on a conversation and that might be cognitively distracting. A lot of my work focused on how to design in-vehicle devices to ensure that they don't distract the driver, but rather support them. And then towards the end of my PhD, I learned about this opportunity to apply human factors in healthcare here in Toronto with a group called Healthcare Human Factors. And so I was fortunate to get the position and I was hooked right away. So in human factors, we spend a lot of time going into people's environments and observing them, not from an auditing perspective, but rather to really understand what are all the system factors that might be impacting their performance. And so I would go in and observe pharmacists and think, I should have been a pharmacist. And then I'd observe nurses and think, oh, I should have went into nursing. And same for physicians. And so I really gained this deep appreciation for the work that healthcare providers do. And it really became obvious that a lot of the challenges that they face are not really a reflection on their lack of knowledge or skill, but rather in terms of how we've configured the systems in which they work. Because in healthcare, we often haven't been intentional with our design. And so fast forward then to 2016, I took on a position here at the University of Toronto in the Institute of Health Policy Management and Evaluation, where I also hold a research chair, the Badeau Family Research Chair in Quality Improvement and Patient Safety, with one of our larger academic hospitals, North York General Hospital. And so this was perfect for me because it allows me to keep one foot in academia and then one foot in the practical realities. And so, yeah, now I lead a team called HumanEra. It's a
Mhm.
deliberate play on words with human error, because we're trying to move away from the tendency still in healthcare to often view humans as the source of the problem and instead usher into a new era of healthcare where we encourage people to come forward with the errors that they make so that we can learn from them and in turn build better and safer systems. So I have a wonderful team and I really love the work that I do.
Wonderful. Thank you so much for sharing that with us. And, I'll let our listeners know if this is the first time you're joining this podcast. I want to sort of let you know to look at like episode 1, which is Surgical Ergonomics 101 with Susan Hallbeck. And the International Ergonomics Association actually defines ergonomics as a study of the interaction of humans with other elements of a system, right? And throughout this ergonomics podcast, we really focus on what we call physical ergonomics, right? So surgeons and other proceduralists, other staff that work in the OR having injuries related to kind of our work environments, instrumentation, all the physical sort of injuries that occur. But Dr. Trbovich actually is studying a different aspect. Well, you've heard her describe this, and this is what we usually refer to as cognitive ergonomics. How are people doing their tasks? Heard her describe sort of the study of errors from kind of that perspective. So, Patricia, I was wondering if you could elaborate for our listeners what cognitive ergonomics means and sort of what sort of things come under that spectrum. For example, I've seen some of your work, the studies you've done with pharmacists in terms of kind of looking at medication errors and things like that.
Yeah, sure. So, well, cognitive ergonomics is a branch of human factors that really focuses on how we design systems to support the way that people think, the way that they make decisions, the way that they manage information, especially under pressure. And
Hmm.
so, if you think of it, it's like, well, physical ergonomics, it really helps prevent issues such as musculoskeletal injuries. Cognitive ergonomics is about protecting our brain power.
I see.
Yeah.
Okay, so I have to tell you, Patricia, that the topic of kind of protecting our brain, as you said, from, let's say, interruptions and distractions in the OR has always been a big topic of interest to me. I wasn't aware that people were actually studying this, but I remember as a resident, you and I have that part in common. I'm a U of T alum as well. I did my surgical training and medical training there, and I remember as residents, we had to leave our pagers at the front desk if we were going to scrub in. They might be another team member who was available to take floor calls and consults to the ER. But if you were going to scrub in, you had to leave your pager. We didn't have cell phones, so you left your pager at the front desk, and then somebody would, answer it for you. I've worked at different places, and at some places, that's not the case. Like people come in with their pagers and sometimes appalled at the fact that, there's no sort of indication of urgency, and then the scrub tech or the assistant in the room is having to answer those pages and, distract kind of the resident from kind of our task at hand to answer something that's been going on the floor. So, I guess from your perspective, I'd be interested in hearing outside of the scenario that I've just described, what are the broad potential consequences of not paying attention to workers' cognitive ergonomics or protecting their brain, as you said, particularly in the OR and procedural areas?
Sure. Yeah. Well, I think like when we ignore cognitive ergonomics in the operating room, we're creating conditions where people are overloaded, they're constantly interrupted and forced into task switching. And so, one of the things that we often hear is people will say, I'm really good at multitasking. But the reality is that in environments like surgery, where there's a lot of multitasking, you're in fact multitasking is not really what you're doing. What you're doing is you're task switching. And every task switch has a cost to it. It burns a working memory, it increases fatigue, and it makes it easier for us to make mistakes. I have a student that just recently completed her master's degree where she was using operating room black box, and I can talk a little bit more about that,
Yep.
but essentially an audio video recording to analyze interruptions that occur in the OR. And so we were looking at it across 3 different hospitals. We specifically chose moments that require high concentration. So for nurses, they wanted us to focus on the first and final count. For anesthesiologists, they wanted us to focus on intubation and emergence. And then for surgeons, it was a mix of like dissection, resection, and anastomosis. A lot of this was during laparoscopic surgeries. And so the task that we observed across all hospitals that was interrupted the most was by far during the second count. So during that final count, when you have to ensure that there's no instruments or sponges left in the patient, and that's a nursing task. And there were some interruptions for sure that were due to people coming in and interrupting. But what we were particularly focused on is the fact that by design, that task is requiring them to do task switching. They're often counting the instruments while also handing instruments to the surgeon. And so, we often think about interruptions as being coming from the outside, but here's an example of how, just in how we've designed the task, we are forcing that task switching. And so again, that's like slowly creeping in. And, that's where, as you constantly chip at that cognitive bandwidth that the nurses have, that's where errors can creep in. And another area that we saw interruptions were for the anesthesiologist during emergence. And so what was interesting across the entire study is that oftentimes it's others in the room are not necessarily appreciating the time when anesthesiologists need concentrated time. So we saw that during, you see it almost in the video. You see the surgeons are done their tasks. It's like,
Right.
there's almost like this, relief because they're just gone through their very difficult part of the procedure. And so the
Right.
nurses, the surgeons start talking. We even see like cleaners coming into the room to start doing the changeover. And yet anesthesiologists are in the most critical time. And sometimes when I've been presenting some of these results, I had an anesthesiologist actually come up to me and say, this really resonates with me because I was in the most critical time of my career, and I could hear chatter and laughing, and people just had no idea of what I was going through. And so that one is just an example of sometimes just helping other people be aware of when you need that quiet time. And we're certainly not trying to say that the OR should be completely silent. Like we get that that's part of the joy of working. And in fact, there are some good interruptions. Like sometimes it's important to interrupt because you need to provide a certain piece of information. But it's really about just being cognizant of those times when different professions require that concentration and finding ways of making other people aware of that.
Wow, this is all really fascinating, Patricia. And actually, just like the anesthesiologist you mentioned, a lot of this is resonating with me. I will come back to that thought, but what I want to do now is kind of pick up on what you said just in this last little bit, and let's see if we can elaborate on that further. So one of the strategies or tools that you're doing to get a sense of, what the cognitive ergonomics are in the room for different people is the OR black box that you just described. If you could let our listeners kind of get a sense of what it actually looks like. I mean, does it really look like a black box, or is it just the name given to it because it's akin to what pilots have in airline? A lot of surgical safety things have come about from airline safety
Yes, yes.
issues. So I'd love to hear a little bit more about that. And also, if you could then expand a little bit more on the other tools that you use to study these disruptions and cognitive ergonomics in various areas.
Yeah, absolutely. So, in terms of the OR Black Box, it's a technology platform that captures synchronized audio, video of what's going on in the room. It's often used in laparoscopic, so we can, if it's used, we can also see the view inside the body from the laparoscopic camera. We get the
Oh, I see. Okay.
yeah, we get the patient's vitals if it's tied to the EMR. If clinicians are wearing wearables, we can also get their physiological response. So essentially, it's this platform that synchronizes all of this information is similar, as you said, to the flight recorder in aviation. And in fact, that's where it got its name, similar to the black box that you hear when there's been a crash. They often go looking for it in the ocean. But the reality is, even in aviation, it's more than just that black box. Like they have access to so many data analytics to really understand what led to the incident. And that's the
Mhm.
same that's being applied in the operating room. Is the idea is that now you can really decipher the details of what led to an incident. And as they say, the devil is often in the details.
Mhm.
And I still remember the first time I heard about the black box. I was actually driving my kids to a soccer game, and on the radio came Dr. Theodore Grancherov, who's the inventor
Right,
of
right.
it. And
Yeah.
he was talking about this new platform. And I remember thinking to myself, where has this been all my life? Because as a human factors researcher, this has really transformed our ability to do our work. Because as I was saying, oftentimes we'll go out into the environment. We always do that. We always have to get a
Yeah,
good
yeah.
appreciation for the work that people are doing. But of course, you can't capture everything, right? You're going to miss
Mhm.
things. But with this platform, we can rewind the video, we can pause it, we can look at it from, and I'm going to look at it from the nurse's perspective, and then play it again. I'm going to look at it from the anesthesiologist's perspective. And so it just allows us to really understand, as we like to say in human factors, work as done as opposed to work as imagined.
I see.
Because, we'll use things like surveys and interviews and
Yeah, yeah.
things like that, but oftentimes people won't think of telling you all of the
Correct,
things that
correct.
challenge them because they're just used to them. I love Margaret Mead, the famous anthropologist, has an expression: what people say, what people do, and what people say they do are entirely different things.
Wow, that's quite profound. I kind of caught that phrase when you said, work as done, not as, someone thinks
Imagine.
it's done or imagined or things like that. So that is so critical. So, by the way, for our listeners, as you heard Patricia say, Dr. Grancherov kind of created the black box, and he was actually the keynote speaker at our recent Society of Surgical Ergonomics 2025 symposium. So if you're interested in learning more about this technology, I urge you to check out, his talk. The symposium recordings will be available if you're a member, so you should be able to do that. But let's step back, as you said earlier, Patricia, in time. Before you heard about this technology and started using it, what were the other tools that you were using to gain information about work, human factors work as it was being done? So you
Yes.
mentioned surveys, you mentioned,
Yeah.
were there any sort of objective tools?
So some of the tools that we use would be a mix of like some subjective and objective.
Okay.
So in terms of the subjective, specifically for getting at cognitive load, I think one of the most known tools is NASA Task Load Index, also known as NASA TLX, which essentially asks people to self-report on
Hmm.
some of the demands on their workload, such as mental demand, physical demand, fatigue, that kind of thing. And so it's great because it's pretty quick and it's been validated in healthcare, and it gives you a quick snapshot of what people's workload is while they're performing a certain task or procedure. But
Hmm.
it's limited in that you're only asking them after the fact, so you have recall bias that can come
Right.
into play, or maybe people are overestimating or underestimating just how much cognitive load. So but at least it gives you, again, like this, at least a subjective perception. And then beyond observations, another thing, I haven't done this, but you
Hmm.
could use physiological or objective measures like EEGs
Oh, I see.
that
Okay.
could track your brain activity or your pupil dilation or your galvanic skin response. And I think those are great because you're getting in real time people's reactions, but they can be difficult to implement in the OR because you're adding more instruments on people. And sometimes the data analysis is not as direct as you might want to. But I have to admit, like I've always, this is a dream of mine, is that someday I would love to have the clinical team wear EEG caps and capture like what part of their brain is lighting up when they're under different
Loads. Yeah.
conditions of uncertainty and that kind of thing. But I just don't think the the research is there yet in terms of
Right.
being able to do that in the live environment. But then oftentimes what we'll do is we'll also just measure behavioral markers. So
Mm-hmm.
with our video analysis, for example, we can tell when there's been an intraoperative adverse event. And
Mm-hmm.
then so we can tell, well, that's a time when there's more uncertainty on behalf of the clinicians. And so there's a
Mm-hmm.
higher cognitive load. And so I had another student, Taylor Ince, who a few years ago conducted a study where she was looking at cases where there was an intraoperative adverse event, and then what were the teamwork skills of the different members. So we looked at
Mm-hmm.
nurses, anesthesiologists, surgeons, and surgeon trainees before the intraoperative adverse event, and then during and after. And
Mm-hmm. Mm-hmm.
what she found was that there was for nurses, the
Mm-hmm.
teamwork skill that augmented the most when dealing with an intraoperative adverse event was backup behavior. So it was
Mm.
things like them noticing, that a surgeon might be too low, their positioning relative to the patient wasn't good, and saying like, do you need a step stool or two?
Uh-huh.
And I think this is important to highlight because it's a good example of how, if you're the surgeon about to perform this safety critical surgery, you're going
Mm-hmm.
to be focused at the task at hand. You're not
Mm-hmm.
necessarily thinking about, oh, is my monitor positioned properly? Is the table at the right height? That kind of thing. And nor should you, right? Because, in aviation, they refer to it as helmet fire, like when you're
Mm.
constant, when there's really that tunnel vision. So you just don't have the cognitive bandwidth to be thinking about all these other things. But other people in the room do.
Right.
So this
Right.
is a nice, and we often refer to this as distributed cognition. So
Mm-hmm.
cognition is not just for you, but how can you try to distribute it in the room? And so I like this example of like nurses in the room are often, they're reading the room. They're
Right.
realizing, hey, maybe you need a step stool or two, just as an example. And so I think that what we noticed there is that we had a huge turnover of nurses after COVID, and then we saw
Right.
that this backup behavior started to drop. And
Uh-huh.
we think that this is because a lot of the nurses that were doing this backup behavior, this is insights that they've gained over years of experience.
Correct.
So now that we know that, now that we've captured that, we can use this information and say, maybe this should be part of the training for the new
Mm-hmm.
nurses. And not only that, but we should really be recognizing that's a really good thing that you did. Thank you. So
Right.
we've been
Right.
using the black box not only to look at safety threats, but what we refer as resilient supports. And that would be an example of a resilient support. Another thing that we noticed in that study is that surgeons and surgical trainees, the teamwork skill that augmented the most from before to after the intraoperative adverse event was psychological safety.
Mm.
So from the trainees' point of view, it was that they were admitting that they were uncertain. And so
Mm-hmm.
we code for that, or they're admitting that they made a mistake. And from the more senior surgeon, we're coding for what is their response when somebody makes
Right.
a mistake. And so, we often see like really supportive behavior, like it's going to be okay. Just get a couple good bites. You're doing well with your sewing job. I mean, we
Right.
see the good, the bad, and the ugly, but it's important to identify those things, because if how you respond to somebody when they're expressing that they need help or that they've made an error is going to make a huge impact on whether they just keep that in their cognitive load or whether they express it the next time. And
Right.
so a lot of our research now is also looking at what are some of those antecedents to speaking up.
Mm.
So we'll go
Right.
back in the video and say, is there anything that we're noticing about the cases where we see a lot of speaking up versus those where we don't? And some of
Mm-hmm.
the early things that we're noticing are very simple. It's how
Right.
many times
Right.
are people introducing themselves to the team?
Right.
It'll be simple things like thanking, uh,
Mm-hmm.
or of the senior surgeon saying, hey, you're new, right? Anything you want to learn today? It's these
Right.
signals
Right.
of you belong here, you matter. And we're
Right.
seeing that seems to correlate with speaking up later in the case. So
Wow.
this is an area that I'm really passionate about delving into more, because I think
Mhm.
that, we often don't realize how much cognitive load is just on that internal dialogue that you have in your head. Do I say something? Do I not? What if I do? And listening to your podcast, actually, now I'm really intrigued in coding for how many times people say they're in pain.
Right, right. My back is killing me is a common refrain in the OR, or my neck is killing me. I've certainly said my neck is killing me several times. And we'll be back right after the short break. Surgeons and proceduralist colleagues, we train for years to master what we do, but most of us are never taught how to protect our bodies while doing our jobs. Neck pain, shoulder fatigue, back stiffness after long cases. For many of us, this isn't the exception, it's routine. That's why, starting on February 16th, 2026, I'm launching the first cohort of a virtual hybrid coaching program in surgical and procedural ergonomics, designed for clinicians who want to perform at a high level without sacrificing physical health or career longevity. The program includes 2 small group sessions plus 2 individualized one-on-one coaching sessions using PoseChecker, which is an AI-based motion capture system that provides personalized, actionable ergonomic insights both inside and outside the OR. I'm Geeta Lal, an endocrine surgeon with over 2 decades in the operating room and first-hand experience with the pain that comes from operating. I'm joined in this endeavor by Linda Miller, an occupational therapist and certified professional ergonomist, and together we bring real-world OR-tested solutions to you. If you're ready to invest in your performance and your longevity, email me at geeta@surgicalergonomics.com to get details and register. Your body is not disposable. Your career shouldn't be either. This is amazing work that you're doing, Patricia, and I can see that you're very passionate about it. And I can see how this will help in the current healthcare environment and I think the future healthcare environment, because like you said, with a lot of staff turnover and not just nurses, but we're in an era of like visiting anesthesiology teams. We're in an area of locum surgeons, in an era of
Yes.
locum surgeons. So there are constantly going to be these new people interacting with each other, and we're not going to have that, as I say, institutional or personal memories of, like you said, those nurses had learned these things over the years. So the more
Mhm.
you can define these things, I think it will help as new groups of people are seeing each other for the first time and doing something, together for the first time. Individually, they've done
Yes.
it, but now doing a task together. And I mean, it seems to work in airlines, right? Because it's not like the same team of pilots flies everywhere, right? But they
Right.
seem to be able to do that. And I think you're right. We need to figure out how to do that also in healthcare because that's where we're heading. I was also intrigued by something you said a little bit earlier, and I think it's a natural segue into sort of what I was going to say in terms of like, potential interventions for improving our, as you said, cognitive bandwidth in the OR and the team bandwidth. One of the things you mentioned is that you noticed kind of the nurses noticing that the surgeon might need an extra set of stools, and I immediately thought of a scenario where the nurses, if something's not going well, they will also signal the medical student on the case that this is not a good time to ask questions. When
That's
when the
good.
medical student starts to kind of open their mouth, they'd be like, shh, nope, nope, not right now. you know.
Yeah.
Or when some random person is coming into the OR at that time, they'll quickly signal them, out, not at this time, because they, as you said, they
Yeah.
read the room, right?
Yeah. That's a
And
really good example.
yeah, and this is an example of where I think also what we're trying to harness in the Society of Surgical Ergonomics. Dr. Julie Halle is leading this developing an OR ergonomics checklist as part of this team ergonomics, right? So
Hmm.
if people set expectations of, what's going to happen in the beginning, applying both to physical and cognitive ergonomics, it will probably make a difference. So, as promised, let's talk about what other things we can do to improve the cognitive bandwidth in the OR. And I'll tell you what I've done, which sometimes I've felt that I perhaps shouldn't have, but I've come up with a phrasing which I feel conveys what I want without hopefully offending other people. Like sometimes when I'm in the middle of trying to find a missing parathyroid and I'm getting really frustrated, or looking for the recurrent laryngeal nerve and a big goiter, and I'm getting really frustrated. And I hear the anesthesia staff and the residents chattering about their teaching, and then the nurses are talking, sometimes about, well, it's break time and this is what's for lunch in the cafeteria and things like that. And I'm just thinking, I really don't want to hear this.
Right.
So, yeah, so sometimes I'll speak up and say, well, everyone, I just want to let you know I'm in the critical portion of the case, or I'm frustrated with something. And if we could all keep the voices down or keep the chatter to a minimum, it would be really helpful. And then when we're done that critical part, I say, now we're good. We're just in the process of closing. Go
That's
ahead,
great.
do what you need to
Yep.
do. So that's something I've learned to say rather than keep getting that internal
Hmm.
frustration. I wondered, what you have observed about what works and what strategies you recommend to people when you do your debrief, for example, of an OR black box situation.
Yeah, well, I think that's great. The example that you just gave. One of the things that I think we can try to do though is try to minimize the time that the clinician has to say it and the time that they're already busy,
I
right?
see.
Like you're already cognitively loaded, and now you're having to try to politely tell people that you need the chatter to go down. And so this is back to where I think if we could be find ways of helping others in the room just know when we need more concentrated time. So, for
Mhm.
example, like a cognitive call out of, I'm starting my final counts. It's like a cue to you that I need some concentration here, or preparing for extubation, or whatever it might be. But some of that language that you could use before so that you're not having to then, kind of getting at it before it actually causes distraction to you. That would be one thing. I think the other thing that we often try to look at is how can we try to design the environment to offload the memory? And so one of the things that we say in human factors is how can we put the knowledge in the world instead of
Mhm.
keeping the knowledge in the head? So things like, checklists can be good for that. But what we found in our study of checklists in a lot of hospitals, it's on an 8 by 11 or whatever regular size
Mhm.
paper in the
Mhm.
corner of the OR, and nobody can really see it, right? So you're
Mm.
expecting people to just go through the safe surgical checklist like off of the what they remember. So just even blowing it up, making it visible. I mean, these are low-hanging fruit type of things, but it nudges people in the right way. A lot of things like you mentioned is I think the biggest thing that we hear from surgeons that drives them crazy is when they don't have the equipment that they need when they need it. And
Right.
so I think sometimes just making sure that we standardize where the equipment is located, that
Mhm.
we do a better job of labeling the equipment. We don't necessarily think of it, but it does add to our cognitive load when you're spending time looking for things, even just like visual indicators. So if there's, I think now with more technology, we might be able to show, for example, that the antibiotics have been given, so that you don't have to ask for
Right.
whether it has been given or not. Other things I think that we can do is look at how many times are we asking people to task switch? Like again,
Mhm.
with
Mhm.
the example of the nurses when they're doing their final surgical count, and how might we redesign that task so that we're not expecting them to task switch? Or if we can't, so in that study that we did, we found that in one hospital they did better, significantly better than other hospitals in terms of the interruptions during that count, and it was because they would prepare in advance of the closure more of the tools and so there was less kind of like chaos
Mhm.
during
Mhm.
the time of closure. The other thing that that institution did is they had a barcode scanner that could keep
Mhm.
track of the sponges. So
Mm.
that's not necessarily reducing the interruptions that the nurse is encountering, but it's giving them a tool to be more resilient to that interruption. So
Right.
now it's not just me that has to keep the count in my head, but I have like a co-pilot, if you will, that kind of keeps track of it with me. So I think we can look into when you can't eliminate the interruption, how might
Mhm.
we come up with a tool such as that that helps people be more resilient to that interruption? And then I think like so another passion of mine is how do people cope with uncertainty? So when you're going from low uncertainty to and you're drifting slowly into
Mhm.
higher levels of uncertainty, we
Mhm.
see that the teams that are low performing, communication tends to dry up. So they're not
Right.
communicating.
Mhm.
Whereas the teams that are higher performing, they talk more. So
Mhm.
it might even be as simple as the surgeon say, I don't know what to do here, but this is what I'm going to try. And I think that's really important because if you're the leader in the room,
Mhm. Mhm.
you're under conditions of low uncertainty. Well, the rest of the team that's working with you, they know
Mhm.
that you're under low uncertainty. But now,
Mhm.
if you cognitively are moving into a level of higher uncertainty, and you don't communicate that to them, they're going to still interact with you as if you're in low uncertainty, right? They can't
Correct.
read your mind. But
Hmm.
if you tell them, they're going to start to, again, read the room a little bit more, notice something, and maybe say it more because they know that you're cognitively overloaded and that you might have missed it. And so, this is another thing I feel like in healthcare, we tend to overvalue standardization and undervalue the importance of adaptation. And
Right.
standardization is so key under low conditions of uncertainty when we know what the best thing to do is and we want to decrease the amount of discretionary behavior that goes into the task. That's where standardization works really well. But we don't have the luxury of always being under low uncertainty in surgery. So, under high levels of uncertainty, this is where you have to rely on people. You want to increase their discretionary behavior. So, we have to think of ways of making sure that people speak up when they should, that they, again, that they have the psychological safety to do it, that they communicate that uncertainty when it's happening. Other things
Yeah.
that we've noticed is if you close the loop with your communication, that's going to make a big difference versus, how many times do we see that somebody's asking for something and there's no response, or that they're asking for something but they're not delegating it to a specific person? So
Right.
I need a crash cart, or, can someone? Well, we have data to show that that significantly increases the amount of time it's going to take to get it, because especially if there's new people coming into the room and they
Wow.
don't
Yeah.
necessarily know, it's kind of whose responsibility is it? So I think those are other things that we really need to think about, is just
Hmm.
how do we help support adaptation? And a
Hmm.
lot of that will just be about more communication and how we communicate.
Hmm.
And then finally, one that I really think would be important is for us to think about what are the key performance indicators that we have in our hospitals, because
Mm.
we tend to focus on what we measure.
Right.
And so I would love to see us not only look at like the percentage of safety threats that happen, but also
Hmm.
be
Hmm.
reporting on what are the percentage of resilient supports that we're seeing. Because I
Right.
think then they'd
Right.
be valued more,
Hmm.
we'd learn from them more. And I think that we'd start to see that other KPIs would improve, such as absenteeism and
Hmm.
things
Hmm.
like that, because it'll just bring a bit
Yeah.
more humanity to our work.
Right. I think I mean, we may not have the data, but what you're saying is that it looks like these things should improve if we focus on these particular things that you were talking about.
Mm.
Wow, as I always say, Patricia, time flies when we're having these conversations, but I want to see if in the last couple of minutes I can kind of leave our surgeons with some practical tools that they can start using today based on all the things that you've outlined. And these are things that I've also learned from you today. So I'm thinking time spent emailing your nursing team or talking to your nursing team the day before the OR about the type of case it is, the equipment you're going to need, the stitches you're going to need, especially if it's outside of things that are usual for you,
Yes,
is time well invested and spent for your cognitive load and your team's cognitive load in the OR,
yes.
right? They know what to expect. You know that what you need will be there and you've communicated that. So that's important. I've paid attention, as I said, to my cognitive overload over the years and have made statements like the one I described to you. And once in a while, I've actually made those statements when the anesthesiologist is intubating a patient with a very large goiter where we might have an airway at threat and we might need to call for extra help and things like that. I'll often kind of go, all right, everyone, we need the room quiet now, even though the anesthesiologist hasn't said anything, because I want to be able to hear what they are talking about within their team so that if they're going to need a surgical airway, I'm ready to do it, right?
Right,
But I
right.
think, but I think I'm going to try and do more of that situational awareness and create that environment of safety where the anesthesiologist can say, okay, we're going to intubate and now we're going to have emergence. So could we please have the room settled or quiet? Okay, whatever
Mhm.
they need. So I got to be cognizant of that. And perhaps all of us can do a better job, all of us surgeons and trainees listening to this podcast. And then the third thing, which I'm absolutely guilty of, which you have said multiple times, is that final count, right?
Mhm.
So, like you said, my cognitive load has come down and I just want to close and be out and get my lunch. Meanwhile, it is a high cognitive load time for nurses and or our scrub techs. And yes, I am very guilty. I'm like next suture, and they're just trying
Right.
to get the count done, right? So I think it would be okay for me to offload some of that from them and say, okay, just give me the suture pack and the needle drivers. We'll load ourselves and keep going, right? You can
That's really,
focus
yeah.
on because I know that I can't stand still while they're doing the count. That would be the
No,
ideal thing if I could do that.
but you
But knowing
can't.
myself, I would just say, I'll load our needles ourselves, just give us the sutures, right? So
Yeah.
I will keep those things in mind, and I encourage other surgeons to think about these things and keep these things in mind. And it sounds to me like, Patricia, we need to have you come back for another episode down the road for, I'll call it Cognitive Ergonomics 201 instead of today's, which is going to be 101.
Oh, I'd
Um,
love
yeah.
to.
Well, again, before we wrap up, I do want to express my sincerest gratitude to you for agreeing to be on the podcast and for sharing like all these nuggets of knowledge and information with us. It's not only fascinating, but it's very practical and very important for the work that we do. So I really appreciate your time.
Well, thank you. As I said, I love your podcast and I really appreciate the opportunity.
All right. Thank you. Please remember to subscribe to the podcast and follow us on social media, Instagram, X, Facebook, and LinkedIn. We love feedback, so please reach out to us for topics, ideas, speakers, or if you ever want to be a guest on the show. Thank you for listening.